Hello, and welcome to the Chest Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Hi, welcome to this month's edition of the Chest Journal Podcast. My name is Matt Siuba. I'm a medical intensivist in Cleveland, Ohio at the Cleveland Clinic. Today I have the distinct pleasure of discussing an article called Adjunctive Corticosteroid Use and Clinical Outcomes in Non-HIV PJP Pneumonia with first author, Dr. Aaron Pulsipher. Aaron, it's great to have you here today. For the sake of our audience, could you please give us a brief overview of who you are and where you work?
Yeah, absolutely. Thank you for the invitation to be here. So I'm a pulmonary and critical care physician at Mayo Clinic in Arizona, where I practice exclusively in the ICU. I've been here for a little over 2 years now. My work is fully ICU based, and I've kind of developed an interest in severe infections and outcomes in critically ill patients. And so kind of to that end, I actually started a research group here that I called the Mayo ICU Inferno. Inferno standing for Infectious Disease Research and Outcomes, and also very fittingly capturing what Phoenix feels like in the summer.
That's a great synergy there, and also really amazing. Got to be one of the better acronyms I've heard in a really long time. So that's great. It seems that you were primed to write about a topic such as as what we're going to cover today in this article. Could you give us kind of a general idea of what inspired the study question?
Absolutely. So after just a few months of working here in the ICU at Mayo Clinic in Arizona, I felt like I was seeing just far more pneumocystis than I really ever did during medical school and in the rest of my training. It really felt like every time I was on service, there was at least one, if not two, patients that were critically ill from pneumocystis. And so this actually prompted me to kind of take a step back and say, how much pneumocystis are we actually seeing across the Mayo Clinic enterprise? And once I started looking, I realized it's a pretty substantial number. And once I saw these numbers, I really felt that we could learn a great detail if we collected the data about this thoughtfully. And so that led me to build a very kind of detailed, high-resolution database that tried to capture a lot of granular clinical information about every case. And as I began abstracting the data, I retrospectively, I think almost naively at the time had this binary variable that I called adjunctive steroids. So I knew if they got adjunctive steroids to treat it. And I realized as I was going through all these charts that really the practice pattern was just all over the map. You had some clinicians that felt very strongly that there's no data to support giving steroids in non-HIV pneumocystis pneumonia. And so even if they're on the vent, they're not getting any steroids. You had others that kind of said, all right, we'll give you maybe stress dose steroids, some that are doing the HIV-derived tapers, some that are doing DEXA ARDS protocols, and some even doing pulse dose steroids. And so really the variation was just enormous. And with all of that heterogeneity, it really made me think that this almost feels like a natural experiment. And if practice is really this diverse, we may be able to analyze dose-response relationships and outcomes in a way that you really can't do prospectively. And so that's what led us to embark on this study.
That is an awesome overview. Thanks for sharing that. That is a great encapsulation for aspiring researchers to say, I notice a clinical problem, and then I'm going to see what kind of data infrastructure I have to work with, and does this lend itself to study? And I think obviously you found here that was the case. So just to kind of understand the background a little bit more, we are talking about corticosteroid use in non-HIV populations. What do we know about the evidence for corticosteroid use in the HIV positive population? And then, even more recently, now there may be some, there's a recent randomized clinical trial about the non-HIV population and treating with steroids. So could you give us kind of an overview of that background? It'll help us tune into your study a little bit better.
Yeah, absolutely. So for HIV-related pneumocystis, the evidence supporting steroids in moderate to severe disease is very strong. And actually, one of the really classic papers of this is in the New England Journal from the early 90s. It's a remarkable study because it only had 23 patients in it. And 12 of them got randomized to get steroids and 11 got placebo. and 9 of the 12 that got steroids survived compared to only 2 of the 11 that got placebo. So just an incredibly small trial, but that early signal just kind of was reinforced by so many larger subsequent trials over that next decade in the 90s and then numerous meta-analyses. And so that's why in HIV-associated pneumocystis with significant hypoxemia, steroids are absolutely standard of care and they're guideline driven. Now, for non-HIV pneumocystis, the story is really completely different. Historically, we've really largely extrapolated from this HIV data, but I think we can all, relate and agree to the fact that the biology and the patient profiles are just not the same. And most of the evidence that we did have what was retrospective and conflicting. You would find some studies that said there might be a benefit, some said no difference, some said actually that we have a signal for harm. And so really the biggest recent advance in this question was released over the summer. There was a randomized controlled trial finally of giving adjunctive steroids in non-HIV pneumocystis. It was a major, well-conducted study, and I honestly think the investigators deserve just a ton of credit because I think prospective research in this population is extraordinarily difficult. And to an extent, I think the trial highlights some of those challenges, but the ultimate conclusions and what it showed is that it didn't meet the outcome of reducing 28-day mortality, but it absolutely did show a very strong signal at improving 90-day mortality and the need for intubation. When you look at some of the details of the trial, though, you notice that some important things stand out. So one key issue is timing. So the median time to randomization for both groups was 3 days, with the interquartile range of both groups going up to 5 days. So you're talking about a quarter of the patients in both groups were not randomized until 5 days or later into their treatment course of pneumocystis. And then another challenging part, too, is when you look at who they screened and then who they ended up excluding, they excluded almost 80 of the 470 patients that they screened because they were already receiving at least 1 milligram per kilogram of steroids for what they said was another indication. And now, honestly, that detail alone highlights why I think this is such a challenging population to do a randomized trial on, because these patients, when they come in, they almost always have something else that you can put on the differential diagnosis for their hypoxemic respiratory failure. You can always blame something like they have underlying antisynthetase syndrome. It's a graft rejection. It's chemotherapy-related pneumonitis. All diagnoses that say, I'm going to give this high-dose steroids. And so by the time they get the pneumocystis diagnosis, the door to randomization for those patients is closed because they've already kind of committed to this alternative diagnosis. And so that's why I really feel like this population is just such a challenging one to try to study prospectively. So overall, I would say in HIV pneumocystis with moderate to severe hypoxemia, steroids rest on a very solid foundation. In non-HIV pneumocystis, even with this randomized trial, I'd say the evidence is much murkier, but there's certainly now a signal for possible benefit.
That's a great segue to launch right into this study that you all conducted. Can you give us a basic overview of the study design?
Yeah, so our main study question was really straightforward. It was, what is the dose-response relationship between adjunctive corticosteroids and outcomes in non-HIV pneumocystis patients who require supplemental oxygen? And so in order to answer that, we compiled a multi-center retrospective cohort of 375 adults that needed to have either proven or probable non-HIV associated pneumocystis. Furthermore, they all had to be requiring supplemental oxygen at treatment initiation in order for us to include them in the study. And our primary outcome that we were interested in was 90-day mortality, with secondary outcomes being 30-day mortality and the need for new intubation, and then also the time to liberation from advanced modes of respiratory support. But because sicker patients clearly tended to get higher doses, we attacked this question using a robust causal inference method where we created something called a marginal structural model with daily inverse probability of treatment weighting.
Yeah, that's a really unique and I think powerful methodology for this type of study. Can you give us an overview for the audience on marginal structural modeling and inverse probability treatment weighting and how you use them, how and why you use them in this study?
Right. So one of the biggest challenges in studying steroids for non-HIV pneumocystis is that treatment is absolutely not random. Clinicians are naturally going to be giving higher doses to sicker patients, and severity is going to be changing in these patients day to day. So if you simply try to do a comparison of high dose and low dose patients, you're mostly just going to learn how sick they are and not really what the steroid actually did. So in order to adequately adjust for all the time independent and then the highly dynamic time varying variables, we use this modern causal inference method, which has two main components. So with inverse probability of treatment weighting, or IPTW, the first step is to create what's called a pseudo population, or my biostatistician prefers to use the phrase pseudo randomization, where you are essentially reconstructing a version of the cohort where patients who received low, moderate, or high cumulative doses now suddenly have all similar comorbidities and similar day-to-day severity. So IPTW lets you rebalance the entire cohort relative to the entire continuous range of doses so that your severity no longer predicts your dose and is no longer just a proxy for how sick that patient is. And so it really lets you isolate the effect of steroid itself. Now, the second piece is the marginal structural model. And in this case, for conducting a marginal structural model with a Cox proportional hazards model to estimate the effect of increasing steroid dose on mortality. So marginal structural models are specifically designed for situations where treatment decisions and illness severity are influencing each other over time and dynamically. So if we think about pneumocystis here, when someone's oxygen needs worsen, clinicians are often escalating steroids. And worsening oxygen also leads to increased risk of intubation or death. So without the ability to account for that feedback loop, standard regression is going to give you biased answers. Marginal structure models are able to break that loop by incorporating both severity and steroid dose every single day. So when you put these tools together, it really lets you answer the real clinical question: does giving more steroid improve outcomes once you level the playing field of severity?
Thank you for that overview. That was very succinct and still complete. I think that one of the things that I thought about before I picked up this paper and started to understand how you all approached it was just that, like how do you account for illness severity and changing patterns in the patient and what the physicians or the treating clinicians are doing from on a day-to-day basis. And you all did that in a truly dynamic way, which is admirable. Now that we have a better understanding of who the patients were in this study and how they were analyzed, what were the key takeaways from this study?
Right. So, I think first the most important key takeaway is that as cumulative steroid exposure increased, we saw a modest but a very consistent increase in the hazard of 90-day mortality. There's about a 1% relative increase per 100 milligrams of prednisone equivalent that patient accumulates over their treatment course. And while that may sound small, real-world steroid doses easily reached into the 500 to 1,000 milligram range, and cumulative effect really adds up and becomes meaningful. Just to kind of give you some ways to kind of calibrate this amount in your head, standard HIV tapers, a full 21-day course comes out to about 820 milligrams of prednisone. And now when you think about maybe something that you have in your ICU with a non-HIV pneumocystis patient as they're getting sick, I think we can all, kind of relate to the experience of, we feel pretty confident in this diagnosis. Let's say you have someone who was on a steroid taper for, immune checkpoint inhibitor pneumonitis, and that is how they got pneumocystis. Your beta-D-glucan it says greater than 500, you have a positive PCR, and maybe you even have a positive smear. So it's there. But now, 7 days into their treatment course, they are now intubated, and now they're up to 80%, and now we're proning them. and they're getting worse. And so importantly, we ask ourselves, are we missing something? And then suddenly our oncology colleagues come up and remind us, hey, we were just treating this person for immune checkpoint inhibitor pneumonitis. Maybe that's actually what's driving all of this. And we standardly treat that with a gram of solumedrol for 3 days. And so you commit to that, and what you've actually just committed to is 3,750 milligrams of prednisone equivalent over 3 days. Now, if you say, what does our model say this is going to happen in that scenario? Remember, our model is on a per 100 milligram basis. And so as you compound that hazard ratio, 37 and a half times, it essentially is now telling you that this patient has now accumulated a 45% higher hazard of death over this follow-up period. And so that's why it may seem like, wow, this hazard ratio is only 1.01, but it's actually, there's a reason that p-value is so low. It's a very significant and very strong signal as you accumulate more and more steroid over time. So that's the first main takeaway, is that we did indeed find a dose-response relationship that gave a signal for worsening mortality over time. And the amount of steroids we offer sometimes sneaks up on you, and you don't realize how much you've given to someone over time. It was impressive, some of these patients, as I'm going through their charts and realizing how much steroid they ended up receiving. The second key takeaway, I would say, is not only did we see this signal of worsening mortality, we didn't really find that there was any convincing respiratory benefit in other outcomes as you accumulate a steroid dose. For us, we didn't see a reduction in the need of intubation. We didn't see patients getting off the vent faster or all forms of, advanced respiratory support faster. And so, our ultimate conclusion, an overarching takeaway from this was, if you're going to use adjunctive steroids, use it cautiously and avoid dose escalation, and be mindful that more steroids is not necessarily going to mean a better outcome in this population.
Yeah, thank you for that overview. It's really informative and instructive takeaways, I think, from this rather rigorous observational work. What are some words of caution that you have for the readers in interpreting these results, or what sort of limitations do you think the readers need to be aware of?
So certainly, at the end of the day, this is an observational study. It is retrospective. We did apply a very robust causal inference method, and we tried to be as granular about the data as possible. When we actually tabulated everyone's steroid dose, I went through it not once, but twice on every single patient to make sure that the daily amount was accurate, the daily severity was accurate. But nevertheless, if you don't put it in the model, you can't guarantee that there isn't still residual confounding. So that's still certainly a possibility. Second, these patients are just incredibly complex, right? And steroids are often being given for reasons that are not maybe just isolated to pneumocystis. And we tried to capture that in what we adjust for in the baseline variables, the non-time dependent ones. But it's tough to sometimes capture all the nuance that is associated with these complex patients sometimes. It's definitely also worth noting that, while this was a technically multi-center, it was still all within a single health system across the Mayo Clinic enterprise. And so certainly practice patterns can substantially vary outside of our health system. Patient populations can vary substantially outside of our health system. And so, the generalizability is always a question when you're looking at such a specific population.
Absolutely. Thanks for summarizing that up for us. Now that we have a good general overview of what's included in this paper, how do you think clinicians should think about steroid use in the non-HIV PJP pneumonia population, considering your work as well as this recent randomized trial?
So I think when you look at these two side by side, for us, a pretty coherent clinical message emerged. So the randomized controlled trial asked the binary question: should we use adjunctive steroids at all in non-HIV pneumocystis? And they used a moderate kind of HIV style taper with methylprednisolone. And while that trial didn't meet its primary 28-day mortality, there was absolutely, a signal that it improved 90-day mortality and intubation rates. So if clinicians are going to choose to use steroids, I do think this randomized trial supports that moderate dose regimen is a reasonable one. Our study asks a different question. Our study asks, does giving more steroid help? And across really every analysis we ran, every subgroup, higher cumulative dose really did not improve outcomes. It didn't prevent intubation. It didn't keep people off of these advanced modes of oxygen support any faster, and was instead associated with a consistent increase in the hazard of death. And so the way I would ultimately frame thinking about this is that if you're going to use steroids in non-HIV pneumocystis, keep the dosing moderate, use something that was tested in the randomized controlled trial, and avoid dose escalation as there's a very real signal that might increase that person's hazard of a bad outcome.
Thanks, Aaron, for that summary. Great paper, great clinical question, and certainly some immediate potential for applicability at the bedside. Any final thoughts for our listeners?
Yeah, something that I think as I've read through all of these cases and have experienced myself now is that non-HIV pneumocystis is challenging. These patients are complex. Their trajectories are unpredictable. They can get sick very, very quickly. And when they do, it sometimes feels like steroids is the one lever that we can pull. But our study suggests that pulling harder on that lever is not necessarily going to make your machine run any better. So really, my closing message on this would be that these are complex patients and really measured decisions matter more than aggressive dosing.
Excellent. Thank you so much, Aaron. Appreciate your time today, and thanks for sharing this work with us and our listeners. As a reminder, everyone, this is we today discussed with Dr. Aaron Pulsipher the article Adjunctive Corticosteroid Use and Clinical Outcomes in Non-HIV Pneumocystis jirovecii Pneumonia, which will appear in this month's edition of the journal. Thanks, everyone, for your attention today, and we'll see you next time.